Welcome back everybody, David here again with Med School Bootcamp. So this next video we're going to talk about something called osmotic diuretics. So osmotic diuretics are a type of diuretic that take advantage of the principle of osmosis. And recall, just as a quick review, what is the principle of osmosis? Osmosis tells us that in a given system, water is going to tend to move from an area of low concentration to high concentration. So given this example here, which way do you think the water is going to move? That's right. It's going to go from the low concentration towards the high concentration. That is the principle of osmosis. And our osmotic diuretics take advantage of that principle. And the two main medications we're going to talk about here include mannitol, which is the most commonly used one, and very rarely, occasionally, urea can also be used for this as well. So when we look at the mechanism of action here, we see that we're increasing the osmolality of the fluid. And recall, the osmolality is the concentration of chemical particles found in a fluid. So if we increase the osmolality, what's that going to do to our oncotic pressure? Well, it's going to increase our osmotic or oncotic pressure and pull more fluid out. So if we think about this from the vascular system, let's say we have a bunch of particles in our bloodstream, and then we add something like mannitol, which I'll draw with orange dots. This is going to increase our oncotic pressure. It's going to cause more fluid to be pulled into the vascular system. Recall, we have a couple different forces when we think about intravascular and extravascular space. We have our oncotic pressure, which deals with the particles in the intravascular space versus the particles in the extravascular space. And then we also have something called our hydrostatic pressure, or the actual fluid pressure against the walls. So we can have some hydrostatic pressure pushing fluid out, some pushing fluid in. We can have some oncotic pressure pulling fluid out, and then some more oncotic pressure pulling fluid in. And the summation of these forces, also called the Starling forces, tells us about the net fluid flow between the capillaries in the interstitial space. So again, by giving these medications, we're increasing the oncotic pressure, we're increasing the pulling pressure into the intravascular system, and thus we're decreasing the fluid that's in the extravascular space. Now, then this should make sense that we're decreasing our water reabsorption and we're increasing our urine output. Because again, as these medications make their way into the tubule, they're going to pull fluid as well. And this is why we increase our urine output. We pull more fluid into the tubules. We pull more fluid into the intravascular space. We're going to decrease our water reabsorption and increase our urine output overall. Now, this can pull fluid into the intravascular space from a variety of different places in the interstitium, but also from the intracranial spaces and the intraocular spaces as well. So if we pull more fluid out of these spaces, we decrease the pressure, which, as we'll see in a minute, can be useful for treating various patient conditions. Now, when we consider our clinical use here, again, just think about things that would require us to pull fluid into the intravascular space, where we want to get fluid from one place to another. If we give them an osmotic diuretic, we can make that happen through the principle of osmosis. So one of the common ones that are tested is the acute angle glaucoma, because again, glaucoma is a eye pathology in which the intraocular pressure is increasing, and to the point that we're actually damaging the eye structures themselves. And so if we need to pull fluid out, we can give an osmotic diuretic, something that will pull that fluid out to decrease the ocular pressure. Now, this can also be used for decreasing intracranial pressure and intraocular pressure. I'll talk about these together because it's the same idea here, right? If we have a lot of pressure in one system, let's say the eye or the cranium, we can actually draw some of that fluid away from the system by giving an osmotic diuretic. So we give the mannitol, which I'm drawing here in orange, and again, the principle of osmosis tells us that's going to draw fluid into the intravascular space, thus alleviating the pressure in the brain or the eye itself. Now, when we think about adverse effects here, we're going to think about things like dehydration. And the reason we mentioned earlier is that osmotic diuretic can actually increase tubular osmolality as well, which can increase the water retention in the tubules and ultimately increase our urine output. Now, this could be a good thing depending on the patient's needs and condition, but too much of it could actually be a bad thing, leading to a dehydrated status overall. We can also consider things like pulmonary edema. This is an adverse effect as well. And this is typically going to occur if we have renal insufficiency in which we're not adequately filtering these substances, or if a patient receives too high of a dose. And that is to say, again, too much of a good thing is a bad thing. If we have too much of this medication prescribed, we pull too much fluid into the extracellular space. Too much fluid in the extracellular space can actually present as pulmonary edema. It can also result in a variety of other findings, such as electrolyte derangements, such as hyper or hyponatremia. And again, this has to do with the fluid shifts, right? So if we shift too much fluid into the extracellular space, this can have a dilutional effect, leading to hyponatremia. However, other things can happen as well. What if we get the dehydration we talked about earlier? This can actually lead us to have a hypernatremic state or a high sodium level as well. And so this medication can cause a variety of different electrolyte derangements that we should be mindful of. And finally, key point here I want you to know is that this is contraindicated in a couple different conditions, one of which is heart failure and the other is anuria, or patients who are not making urine. And the reason this is contraindicated in heart failure is because this can actually pull fluid into the intravascular space. This can worsen the condition. Remember, in heart failure, we have a faulty pump. That faulty pump leads to less fluid being sensed by the kidneys, which activates the RAS system. That brings back more sodium and brings back more fluid. So people who have heart failure are already volume overloaded, and that is why we see the worsening heart failure. People who have anuria typically have a very low urinary output, typically less than 50 milliliters per day, although some sources will also reference less than 100 milliliters per day. The idea here is that they're making very little urine, and so they're not actually filtering these substances. They can get an overload of the osmotic diuretic, which can lead to some of our adverse effects, including a volume overloaded status and pulmonary edema as well. So a possible vignette for this medication could include something along the lines of a 7-year-old patient is in the ICU following a neurosurgical procedure. The overnight team notices that the patient's neurological exam is changing significantly, including alterations to their cranial nerve exam. The patient's reporting increasing headache and pressure in the head, and the team suspects that there is an increase in intracranial pressure following the neurosurgical procedure. What medication could be given? Well, mannitol is an option here, right? If we pull some of that fluid out from the cranium and we pull it into the vascular system, that's going to relieve some of the pressure. And so that would be the best medication that they would use here. Now, keep in mind, some other options that they could give you that might trick you could include things like loop diuretics, thiazide diuretics. You might just think that we need to offload fluid from the patient overall. But the key here in this question is that the patient is experiencing increased pressure in the head itself. And so we need to do something fairly rapidly to pull fluid out of that system. And so loop diuretics and thiazide diuretics would not be the best answer here. So finally, just a quick summary of this video. We're talking about osmotic diuretics. Remember the principle of osmosis. Water is going to tend to flow from a low concentration to a high concentration of substances. That's how these molecules work. Typically, we're using mannitol. Rarely, we're using urea. This is going to increase our osmolality, increase our osmotic pressure, our pulling pressure into the vascular system, which can also pull fluid into the tubules, leading to decreased water reabsorption and an increased urine output. This can be used for a variety of different things, including acute angle glaucoma, increased intracranial pressures, and increased intraocular pressures as well. How? Because it draws fluid out of the area. We draw fluid into the vascular system. This is going to relieve some of that pressure in the cranium or the eye itself. Finally, some adverse effects that we need to be mindful of are dehydration, right? If we pull too much fluid into the tubules, we increase our urine output too much, we can get dehydrated. We can also consider that pulmonary edema and electrolyte derangements can be a problem as well, depending on the shifts of the fluid. And finally, key contraindications are going to include heart failure. Why? Because these patients are already volume overloaded. We don't want to pull more fluid into the vascular system itself. We're compounding a worsening problem. Also, patients who are anuric or are not producing significant amounts of urine. Why? Because these molecules can build up in the body, leading to some of the other adverse effects that we mentioned previously, such as pulmonary edema.